Hi there, it's Matt here, and welcome back to the podcast. Today, we're going to be discussing a sleep disorder in which you act out your dreams, and it is called REM Sleep Behavioral Disorder, also known as RBD for short, REM Sleep Behavior Disorder. REM Sleep Behavior Disorder is characterized by the physical enactment of dreams that occur during rapid eye movement sleep. As we've mentioned before on this show, that is the stage of sleep from which we typically have very vivid, very motoric, very movement-based dreams. Taking a step back, we've also discussed, probably in some of the very first episodes of this podcast, what happens during normal REM sleep. In a healthy individual, when we go into REM sleep, your brain, and specifically your brainstem, will paralyze the rest of your body so that you do not act out your dreams. And this is a state of muscle paralysis. Now, the technical medical term for this is atonia. As we've mentioned before, anything in medicine usually with the word a before it indicates the absence of it. So arrhythmia, the absence of a normal rhythmic heartbeat. And here the term is called atonia, which is normally when we go into REM sleep, our brain paralyzes our body so our minds can dream safely. And we don't have, as a consequence, any muscle tone, hence the absence of muscle tone, otherwise known as REM sleep atonia. And by the way, you can imagine this is a very smart evolutionary mechanism. What we don't want to be doing when we're not perceiving the external world, our eyes are closed, we can't see what's around us, it is dark. If you were to start dreaming that you could fly, under those conditions, you may be popped out of the gene pool very, very quickly. Nature came up with a very clever mechanism called REM sleep paralysis. So we still get to dream and have all of the motoric, physical, movement-based aspects of dreaming, but without the dangers. And this brings us back to REM sleep behavior disorder. Because in REM sleep behavior disorder, this paralysis, this normal atonia, is absent, or at best, it's incomplete. And it means that the individual will start moving around during their sleep, sometimes thrashing around, some violent movements. They can be talking. And as I said, they can act out some really quite complex behaviors. And what they're doing is acting out the content of their dreams. Why? Because the brainstem has failed, and we'll come on to explain why it fails. It has failed to send the signal that is normally sent just before we go in to the dream state all the way down your spinal cord, and it impacts something called the alpha motor neurons of the spinal cord and blocks them. And those things are associated with our voluntary movements. And unfortunately, that brainstem mechanism fails to effectively send the signal down the spinal cord to inhibit you and lock you into a physical incarceration within your body. And therefore, because of the absence of that muscle paralysis, you start acting out your dreams. And today I'm going to explain this sleep disorder, which is part of a neurological set of disorders. And we'll speak about both what REM sleep behavioral disorder is, also what it is not. And it's really important for me to emphasize that because of any concerns for people. I'll tell you about the etiology of it, the causes, the underlying basis of REM sleep behavioral disorder. We'll speak about the diagnosis, and we'll speak about some of the treatments and also the prognosis. Let me begin with what REM sleep behavioral disorder is not. Before I tell you what REM sleep behavioral disorder is in much greater depth, let me tell you what it is not. And it is so critically important to know what it is not, especially to dispel any myths or prevent anyone from getting unduly worried when they don't have to be. REM sleep behavioral disorder is not typical sleepwalking, sleep eating, sleep talking, because those things do not occur during this dreaming state that we call REM sleep. And it's perfectly natural for you to think that when someone is sleepwalking, for example, that they're dreaming and they are getting up and they're walking around because they're walking around in their dream. That's actually not the case. If you were to gently wake them up and say, what was going through your mind just before I brought you back to consciousness? They won't tell you anything, say nothing, because their mind was blank. Why? Because they weren't in the REM sleep dreaming state. Sleepwalking, sleep talking, sleep eating, sleep sexting, all of these things actually come from a class of non-rapid eye movement sleep disorders, not REM sleep. And those non-REM sleep disorders come under an umbrella term described as the parasomnias, meaning para, things that are around, somnus, obviously, from its Greek etymology of sleep. So these are things that are not quite sleep, but occur around sleep. And that is sleepwalking, sleep talking. Night terrors are also one of these non-REM parasomnias. And I will do a whole episode on those. I know many of you have been asking me about them. But that is not REM sleep behavior disorder. What unfolds during REM sleep behavior disorder is very different to sleepwalking. And as I mentioned, you start to act out your dreams in a very complex way because you've lost the paralysis mechanism from the brain that normally blocks you acting out those dreams. So if that's what REM sleep behavior disorder is not, let's get into exactly what it is. And I will start with its etiology. In other words, the instigating cause. That's just a fancy medical term, meaning what are the underlying forces that lead to this condition? Well, it turns out that for REM sleep behavioral disorder, there are numerous predisposing factors, and these include getting older, in other words, age, your sex, and specifically if you are male, other certain sleep disorders, such as narcolepsy, as well as some degree of antidepressant use, and also certain neurological conditions. And I'll come back to those in a second. We divide REM sleep behavioral disorder into three subtypes. One of them is called idiopathic REM sleep behavior disorder. The other is called drug-induced REM sleep behavioral disorder. And then the third is what we call secondary REM sleep behavior disorder due to some other form of a medical condition. Now, the latter two, drug-induced REM behavior disorder and secondary to a medical condition REM behavior disorder, those are not the principal ones that we're going to focus on today. The initial one, called idiopathic REM sleep behavior disorder, is the one that we are going to focus on primarily today in this episode. It is the pure condition, as it were. For those who are struggling with sleep, one recommendation that I've mentioned on this podcast before is meditation. To be honest, I was a complete skeptic at first. I just thought it was all a little bit out there. But the data was just so strong for sleep. So I tried it, and that was 7 years ago. And I've now been meditating for 10 minutes before bed every night. The app that I've been using is called Calm, and I decided to partner with them. And Calm have agreed to offer a full 40% off its premium subscription to you, the listener. So if you want to get that 40% off and start your meditation journey, just go to calm.com/Matt Walker. So that is calm, CALM.com/Matt Walker. Idiopathic, by the way, what does that word mean? It sounds strange. It means to come from inside of oneself. And since we do love words on this show, let's speak about the etymology, the underlying history, the premise, the basis of that word. Idiopathic comes from the ancient Greek idios, which is one's own or one's proper, and pathos, meaning to suffer from, in other words, a disease. So idiopathic literally means a disease of its own or a disease of one's own. And as I mentioned at the start of the show, REM sleep behavior disorder is a sleep disorder of neurological origin, meaning of the nervous system. More specifically, REM sleep behavior disorder is caused by neurodegeneration, which simply means brain cell death. Why are brain cells dying in patients with REM sleep behavior disorder? It seems to be because they have an abnormal or an excessive amount of a particular protein in their brain called alpha-synuclein. Alpha-synuclein, if it is building up in excessive amounts, will kill brain cells. And what we know is that REM sleep behavior disorder is characterized by the buildup of this alpha-synuclein protein, but not all over the brain. It seems to occur in some parts of the cortex, which is that wrinkled surface that sits on top of the brain, but particularly down deep in the brain. In fact, all the way at the bottom of the brain in a region that we call the brainstem. And it is the brainstem where that mechanism that I described, that just before we go into REM sleep, the brainstem recognizes this transition. And as it's getting ready to fill the cortex with extreme activation called dreaming, it sends another signal south down the spinal cord to paralyze the rest of your body. That is occurring in the brainstem, and it's in the brainstem that this protein, alpha-synuclein, will build up in excess and damage those brain cells in the paralysis mechanism regions of the brainstem. If you are particularly neuroanatomical curious as I am, the actual brainstem regions include what we call the pontine tegmentum regions and also the medial medulla. And it is those regions which are critical for inducing the normal and natural REM sleep paralysis, but the regions that become dysfunctional in REM sleep behavior disorder. I should also note, and I'll come back to this at the end, that REM sleep behavior disorder is unfortunately associated with other neurological conditions. Those conditions include Parkinson's disease. They also include something called Lewy body dementia, which is actually one of the neurological conditions that I focused on when I was doing my PhD and I was working with those patients. REM sleep behavioral disorder is also associated with several other less common neurological conditions, such as Wilson's disease, which is a genetic disorder leading to actually a copper accumulation in the body. Also, narcolepsy, and we've discussed narcolepsy before. It has an episode all of its own on this show that you can go and find, as well as something called autoimmune encephalitis, which is an immune system attack on the brain. But those latter ones, including narcolepsy or Wilson's disease or autoimmune encephalitis, those are much more rare. Oh, and that reminds me, there are some pieces of suggestive evidence, and it really is just that, of REM sleep behavior disorder being part of an autoimmune abnormal response, where the immune system starts to strangely attack those brainstem regions. Now, again, these are just very tentative early studies suggesting that, and I mention it not for want of giving false hope, but if that is true, in the future, it may suggest that some cases of REM sleep behavior disorder may respond to treatments that target the immune system, if that is the case. So that's me telling you a little bit about the underlying cause of REM sleep behavior disorder. And I will say more about that in just a second. But let's ask the question, how common is REM sleep behavior disorder? And that brings us on to the epidemiological data assessing how frequent it is that people will develop REM sleep behavior disorder. And while those studies, those epidemiological studies, are limited in their quantity, they suggest that the prevalence is around 0.5% in the general population. But this isn't really the right way of asking the question. Remember that I told you earlier that it is a condition that we see in those really once they get to mid and especially later adult life. And when you look there, the prevalence significantly increases in the aging population, with REM sleep behavior disorder being present in between 5 to 13% of adults age 60 to 99. I know that may not sound a great amount, but if you were to calculate the numbers, it is a staggering amount. The onset of the symptoms for REM sleep behavior disorder, the acting out your dreams, typically occurs, and again, it can occur earlier, but it typically occurs when people are moving into their 60s and their 70s. But again, we've seen it happen in younger people as well. I also mentioned that sex matters here, and there is a very strong male predominance, specifically in the older population. So if you look at people who are 60 years and older, REM sleep behavior disorder occurs far more frequently in men than it does in women. But what's strange is that if you really dig down into the data and you look at younger cohorts, people who are in their 50s or below, then the distribution is equal between males and females. And we don't quite know why. We also don't quite know why there is a significantly higher risk of individuals with psychiatric disorders also developing REM sleep behavior disorder. Indeed, what we found is that in patients who are receiving antidepressants and patients with certain psychiatric disorders, there can be anywhere between a 5 to 10-fold increased likelihood of those individuals also going on to develop REM sleep behavioral disorder. To be very clear, those studies are what we call associational studies. Just because you are, let's say, taking antidepressants or have a psychiatric disorder does not mean that they are causing the higher likelihood of developing this condition later in life. That is not what those data can claim. It simply means that those two things are associated. Individuals taking those medications or who have those psychiatric conditions seem to be at a higher risk of developing REM sleep behavior disorder later in life. So that is a little bit about the prevalence and some of the associations. Let's turn to diagnosis. If you were in an exam room with a doctor or you were the attending doctor, there is a flow of initial diagnoses that go as follows, and it progresses on to a more detailed diagnostic assessment. REM sleep behavioral disorder diagnosis hinges on two key symptoms: the lack of normal muscle paralysis during REM sleep and the physical enactment of dreams. And it is these two sets of features that the paralysis that normally should be present is lost. That leads to the second consequence, which is that people start acting out their dreams. That is normally the thing that is presented to the doctor. That is what we call the primary complaint, either of the patients themselves or usually of the wife who is asking for help regarding her husband. Because, as I mentioned, it's typically more common in men than it is in women. And of course, it's not just the concern to the patient, although that is one of our main principal concerns, is trying to limit self-injury caused by acting out one's dreams. But due to the fact that often the dreams that are acted out can be violent in nature, there is a concern about the safety of the bed partner. A sponsor of today's show is Inside Tracker, which is a service that comes out to your home and they will analyze your blood and your DNA to know precisely what is going on inside of you. Hence the name Inside Tracker. They look at your blood, your metabolic signals, your hormonal health metrics, and then they give you a personalized, actionable set of lifestyle changes in response to that readout. And the goal there is to improve your health. I was looking and informed they have some new cardiovascular and new hormonal biomarkers that I'm particularly interested in. One that I'm focused on is something called ApoB, which is an absolutely critical heart health measure. And I get it done now with them somewhere between 4 to 6 times a year. Why? Well, my family unfortunately has a strong history of cardiovascular disease, so I am checking that pretty ruthlessly. And by the way, I do buy the product myself out of pocket. I don't want to fall prey to any of those trappings and undue incentives. Although with full admission, I still use my own discount code that you can use to get some money off. And that code for you is insidetracker.com/Matt Walker. So just go over to insidetracker.com/Matt Walker. And again, if you want to get that discount, it is insidetracker.com/Matt Walker. Thanks very much. And during one of these enactments, as I said, it's usually in response to a very undesirable or violent dream where the patient is being attacked, they're being chased, or they're being compromised in some way. And after the enactment of their dream motions, they will often wake up abruptly with prompt alertness, and they can recount vividly a coherent dream. And this is one of the things that makes it very different to simply sleepwalking. And you may think, well, if I'm asleep when this is happening, how likely is it that I myself, let's say I don't have a bed partner, would know about this? Well, it turns out that more than half of the patients with REM sleep behavior disorder are usually aware of their dream enactment behaviors. How frequently do these things occur? Well, there's a huge range. It can be maybe just once a month or once every 3 months, to then it progressing to an intensity that can be almost nightly. And although some of this can happen in the first half of the night, these are really usually occurring in the second half of the night. Why is that? Well, if you listen to this podcast enough, you will probably already have understood why. Because REM sleep principally comes alive in the second half of the night, and particularly the last few hours of the night. And it is from REM sleep that this disorder emerges. And for education of anyone out there, normally the way we see this unfolding includes stereotypical hand motions, sort of reaching gestures or punching and kicking. These are the typical types of behaviors that reflect REM sleep behavior disorder. But of course, just asking the patient and confirming these things are happening does not make the diagnosis. The diagnosis requires them coming into a sleep laboratory for objective validation of diagnosis. And we apply electrodes to the head and to the face and to the body, above and below the eyes. And that way, we're able to measure, firstly, when the patient goes into REM sleep, but using some of the electrodes on the body and the face, there we're measuring the muscle activity, or what we call the electromyogram, which is simply to say the electrical activity, a graph of the electrical activity coming from the muscles. Myo, graphy meaning a graph, and electro meaning that the currency we're dealing in here is electricity. So an electrical readout of muscle activity, the EMG, is what we're going to measure. And normally in a healthy individual, just before they go into REM sleep, all of a sudden, bang, you get no muscle tone whatsoever. You're usually getting this somewhat, it almost looks like a static ebb and flow, this sort of thick red ink going up and down on the trace as time is moving forward. That shows that there is still some muscle tone during non-REM sleep. And just before they go into REM sleep, all of a sudden, that line just goes to a tiny thin line. There is no muscle activity whatsoever. And at that moment, you've gone into paralysis. And then we start looking at the eye channels, and all of a sudden you start to get these rapid eye movements, and off and away you're dreaming. The brain bursts into life, and that is normal and healthy REM sleep, with the muscle paralysis indicated by the absence of muscle tone, atonia. But in REM sleep behavior disorder patients, we see that they're moving through non-REM sleep, and then all of a sudden they start to have these rapid eye movements. And then the brain fires up in its frenetic electrical activity, but there is still really quite strong presence of muscle tone. The muscle paralysis has not been switched on. Their brainstem has lost the ability to turn on the atonia and to prevent them from acting out their dreams. And soon after, they may indeed start acting out their dreams in the sleep laboratory. I should also note that there are some additional questionnaires that are frequently taken to confirm diagnosis for screening, or at least they're taken for initial screening. There are 2 single question questionnaires that have been established, one by the Mayo Clinic, and it's called the Mayo Sleep Questionnaire, and then something called the RBD1Q. If you are really interested. The Mayo Sleep question was tested out, I think it was in the general population, and queried bed partners. And it has a very strong sensitivity of what we call 98% sensitivity, which is a very sensitive test, and a fairly good degree of specificity. So here, I won't bore you with the statistics. My friend Peter Attia probably has numerous beautiful descriptions of what the difference is between sensitivity and specificity. But here we're talking about confirming true positives and making sure that we are staying away from any false negatives or not accurately confirming someone who has it as a false negative. So the specificity is about 74% for confirming REM sleep behavioral disorder, and its sensitivity 98%, so very good at detecting whether you have it. The question goes as follows. Have you ever seen the patient appear to act out his or her dreams? And in parentheses, punching or flailing arms in the air, shouting, screaming, while they are asleep. The other one, called the RBD1Q, that was tested in sleep centers, and that has actually an even better performance. It has a sensitivity of 98%, identical to the other one, but a specificity of 87%, and it asks the following. Have you ever been told or suspect yourself that you seem to act out your dreams while asleep? For example, punching, flailing your arms, making running movements, etc. So, together with the presenting symptoms that a physician will ask about and the sleep laboratory recordings, together with using these screening tools up front as initial suggestions of diagnosis, and those questionnaires do go up front to begin with as screening tools, but they're not necessary. That is how we confirm an objective clinical diagnosis of REM sleep behavior disorder. So now let me come on to the treatment and then finally the prognosis. At present, there is no cure for REM sleep behavior disorder, sadly. The primary treatment goal of REM sleep behavior disorder is to reduce the risk of injury to the patient and to the bed partner. That is the primary approach that we take. This usually involves a change in the routine sleep habits that may prove challenging for the patient and the partner. But we try to emphasize that and tell them the main reason you want to adhere to these recommendations is for your own safety and that of your partner. And so we typically offer an education, and it speaks about the following: trying to mitigate fall risk by lowering the bed much closer to the floor. The second safeguarding any firearms, any knives, or any other weapons in the home. The third is building out cushioning or padding on the floor or around sharp furniture surfaces. The next is placing patients in restraining clothes or in sleeping bags. I know that sounds almost barbaric in its nature, but some patients will come in and present and they will already be saying, I was so terrified that I could harm my wife. I was so absolutely petrified that I have been sleeping in a sleeping bag that zips all the way up, all the way over my head for the past 2 years because I refuse to let whatever this thing is that's happening to me harm my wife. I could not live with myself. And then perhaps you may be thinking the most obvious one then would be to separate the partner from the patient to reduce the risk of the injury. Now, of course, that doesn't reduce the injury risk to the patient themselves, and that's why things such as restraining clothing or sleeping bags are still suggested. The other supporter of this podcast is the electrolyte drink company called Element. Now, it's actually 4 letters, LMNT. I am a bit of an exercise fanatic, and I started buying their products some years ago, really, because of 2 key facts. First is the lack of sugar content. Element has no sugar. It also has no colorings, no artificial ingredients, which is unlike many of the other mixes out there that I was shopping. The second is because of the founders, who have some serious years of biochemistry experience under their belts, and they know what they're doing. So if you want to give it a try, just go to drinklmnt.com/Matt Walker, and you will get 8 free sample packs on any order that you place. Once again, that is drinklmnt.com/Matt Walker. What about medications? Well, there is one that is typically tried with REM sleep behavioral disorder. It's actually one that I've spoken about before many times on this show. I've spoken about how it is not very effective for the condition of insomnia based on the data and the clinical recommendations. But one of the preferred pharmacological treatment approaches for REM sleep behavioral disorder is the compound that we call melatonin. As you will remember, melatonin is a hormone. It is secreted by your pineal gland, and it's associated with your circadian rhythm. And its secretion is influenced by light exposure. So when there is light exposure, the brakes on melatonin are tamped down. And when we get a good amount of darkness at night, those brakes are released, melatonin flows out, and we can help the timing of our sleep. Although the mechanism for exactly why melatonin can be modestly effective in REM sleep behavioral disorder patients, we still don't quite know why melatonin may be efficacious to a modest degree in patients with REM behavior disorder. But currently, the recommendations, if you look at some of the clinical guidelines, are somewhere between 3 to 12 milligrams of melatonin at bedtime. And it has been demonstrated in small studies to have a modestly reducing subjective sense of your REM sleep behavior disorder symptoms. If you look at objectively the symptoms, they don't seem to change as much, but at least the patient says subjectively, I feel as though things are better when I'm taking the melatonin. Here, by the way, medicine does not use over-the-counter melatonin that you would buy at a supermarket or online. They use clinical grade melatonin, and specifically a formulation that is called Remeltion. And it is what we class as a melatonin M1/M2 receptor agonist. In other words, it mimics melatonin in terms of its chemical structure, and it goes after the 2 principal melatonin receptors in the brain, and it stimulates them as if it's mimicking the action of melatonin. And Remeltion, this medical grade version of melatonin, is at least FDA approved, unlike the things that you buy over the counter or in the supermarket or online. Another medication that, if you look into the literature, has been used is something called clonazepam. And it seems to be a somewhat effective treatment for RBD and has, in fact, if you look at the literature, it has been considered for a long time now as the first line pharmacological therapy for REM sleep behavioral disorder. What is clonazepam? Well, clonazepam is what we call a long-acting benzodiazepine, and it has a half-life of about 30 to 40 hours. In other words, after about 30 or 40 hours, 50% of it is still in your system. Nevertheless, it does peak quite quickly, somewhere between about 1 to 4 hours after ingestion. And if you look at the clinical guidelines and the medical recommendations, it's an initial dose of around about 0.25 milligrams 30 minutes before bed, and then gradually increasing the dose can get as high as, if you look at some of the papers that I've read, as high as 4 milligrams. But in truth, it's really the lower dose that is recommended just because it limits the amount of potential abuse and the amount of tolerance. Benzodiazepines are drugs that are readily abused. They can be quite addictive, and you can build up a tolerance to them. Nevertheless, even at the low doses in this condition, common side effects have been observed, such as just feeling still groggy and sleepy in the morning, a significantly high risk for falls, memory dysfunction, so forgetfulness, finding it hard to memorize things. Been some reports of impotence in males, and also just unstable gait, which is an unstable walk and its stability. Other non-pharmacological treatments that are, at least from all I know, right at sort of the leading edge, that are under investigation is probably the best way of describing it, or early development, are plasma exchanges as well as deep brain stimulation. And there was one study on patients with REM sleep behavioral disorder linked to Parkinson's disease, and they did find that deep brain stimulation. This is where neurosurgeons will go in and they will place electrodes down into the brain, and those are connected to a stimulator, and they will stimulate certain deep brain regions. That did seem to reduce the risk of these REM sleep behavior disorder events. But again, those are at the very early stages. So, what about the outlook here? What about what we call the prognosis? Well, the prognosis of REM sleep behavior disorder really depends on the etiology, and that goes back to those three main flavors. But here today, we were really speaking about the primary flavor, which is idiopathic REM sleep behavioral disorder. Its development, you should be aware of, is slow. But I do want to be honest and note that it is still slowly progressive. This is where some hard news comes into play. Among those with a confirmed diagnosis of REM sleep behavioral disorder, there is a very high correlation, to anywhere between 30 to 50% of individuals seem to go on to develop Parkinson's disease. About the same amount, if not higher, will go on to develop something called Lewy body dementia. And then another proportion of patients, around about those same percentages, can go on to develop something called multiple system atrophy. It's very difficult news. Just because someone has REM sleep behavior disorder does not mean that you will develop those conditions. It simply means that there is significantly higher likelihood that that may be the case. As a result, once we confirm the diagnosis of REM sleep behavioral disorder with the patient, the clinical team will then very gently discuss the associated neurodegenerative disorder risks that I've just described and the prospects realistically, and then speak with the patient about planning. And the patients are then, because of that REM sleep behavioral disorder diagnosis, and hence now the significantly higher risk, they are very closely monitored for any signs of neurodegenerative disorders. And then these patients are not always, but typically introduced to what we call neuroprotective therapies. And these include emphasizing the rigorous importance of regular exercise, somewhere between 120 to 150 minutes per week. And those things, together with dietary and lifestyle changes, can try to de risk the potential for developing those neurodegenerative conditions. So, folks, that is a look at the sleep disorder and the very challenging disorder to discuss because of the ramifications called REM sleep behavior disorder. As always, this episode simply offers scientifically descriptive information, not medically prescriptive information. Feel free to take this information that you've learned to your doctor as a patient or as the partner of someone that you think may be showing such signs that reflect REM sleep behavior disorder, and seek their advice and a referral. Thank you so much again for listening. Thanks so much for supporting the show by listening. Lots of you have been kind enough to leave a review on the Apple Store and other places. I never ask you, I'm always kind of sheepish to say, if you enjoy it, could you review? Because I know that's what everyone tells me, that my team say, do please ask. That really makes a difference to the show and getting out to more people. I just don't like self-selling. I'm so sorry. So thank you for people who've left a review, and upon hearing this, do not feel any compulsion whatsoever to go and write a review of your own. Oh, and before I forget, something that I will promote is that I am now doing an AMA episode every month, in addition to the 2 standard episodes released every month. Keep posting your questions on social media. I love doing these. So send all of your questions. There is never any shortage of questions. And for now, I will simply say, take care of both yourself and be caring for and of others around you. And I will see you in the next episode. Thanks so very much, and bye for now.